to assist with human reproduction. It's my pleasure to introduce Professor Herman Tournaye, who is the head of the Center for Reproductive Medicine at the VUB Center in the north of Brussels.
Thank you, Mr. Chairman, for the introduction, and thank you for the invitation to share something completely different with you, I would say. First, I think it's honest to say that we received some grants from some companies, although I don't think there's really conflict of interest there. What I will go through is first trying to tell you why it's important to preserve fertility, then what the options for children are, how far we are with the clinical application, and then just to wrap up, so to take home messages. Why would you think, or should you think, or I would even say, must you think about fertility preservation? Well, basically, I would like to start with explaining or rehearsing to you the way the gametes are stored or produced. So basically, in boys, as you know, boys are born with stem cells in their testes. They don't produce sperm. It's only from puberty onwards that sperm will be produced. Because it's stem cell driven process, they will go on until, depending on your cardiovascular situation, you can go on until 70, 80, 90 years old, depending on the vascularization of the testes. Girls is a completely different story. Girls are in fact born with oocytes. The stem cells, they are gone, because already during their fetal life, the stem cells are going into a differentiation process, and eventually they go into meiosis, and then the oocytes derived from the stem cells, they are arrested in the prophase of the meiotic division. So in fact, girls are born with a certain reserve, a fixed number of oocytes, while boys can still produce oocytes up to the older age. This is a slide that probably is already quite old. I mean, 2007, and shows that for many cancers, survival rates are very high. We heard from previous speakers that's 70–80% survival rate. So nowadays, in fact, it's also becoming important issues like quality of life, including fertility, of course. For girls, it means that in fact the process, they are born with, for example, 1 million oocytes in their ovary, and over time the numbers decline, whether you're pregnant or not, whether you're taking a pill or not, whether you're 10 years or 30 years, you're losing your eggs all the time. It's only when you reach puberty that once a month you can produce one mature egg. But if you're confronted with a gonadotoxic treatment, radiation or chemotherapy, what happens is that the loss goes very quickly. In fact, you drop, and at 10 years you end up with a certain number of eggs which probably are, for example, can be the same as somebody is 40 years old. So be careful if you say after gonadotoxic treatment, no worries, because the girl of 30 years old is still menstruating. Yes, she will be menstruating, but maybe for only a couple of years, because again, as with adults, there is a decline in the numbers, but even after chemotherapy, for example, the decline will be much, much quicker than in normal natural life. So in other words, if a girl gets chemotherapy, radiotherapy on the ovaries, there is indeed a big problem for the fertility on the long term. Same for boys, but here, of course, the stem cells are there. They are dividing, even in before puberty. Some may reach meiosis. They never go into full differentiation, and it depends on, of course, the course of the chemotherapy. What is left over. If some stem cells are left over, you're on the safe side. Over years, they can recolonize the testes, but if they're all lost, of course, then there's a big problem. Then you end up with no stem cells, and of course, once puberty is there, no production of sperm whatsoever. Fertility, and of course, keeping your stem cells as a boy or keeping your ovarian reserve as a girl, for us, it's part of quality of life, and I think for you the same. And in fertility, in the last 10 years, I mean, There have been no novel treatments being introduced, but the treatments that were available have become not only efficacious but also very efficient. And nowadays, in fact, we can offer quite a lot of things to not only adults but also to children. And there is a domain, a new subdomain, which is called oncofertility, which is really targeting coping with problems of gonadotoxicity in, for example, adults but also in children. So what are the possibilities nowadays in theory? First, let's focus to boys. Again, boys are not, before the puberty, they are not producing spermatozoa, so sperm banking as we do in adults, out of the question. So here the focus should be on the stem cells that are in the testes available. And in fact, in 1994 already, a group of Penn State University, they published a model. In fact, the idea was to generate transgenic mice, in which they showed very elegantly, using a transgenic mouse model, that indeed if you make suspensions of the tissue of a mouse and you transplant the suspensions into a host, this host will eventually produce sperm derived from the stem cells that you transplanted. And of course, this is a nice setup, a nice strategy in which we could try to get things going on for children, for boys. So a boy could get a biopsy, and the stem cells from the biopsy are cryopreserved, and later, at adult age, after being cured, these stem cells can be transplanted into the testes and hopefully produce sperm. So that's the idea. Practically, there are two possibilities. You take tissue, you make it into a suspension, and you go for infusion of stem cells in the seminiferous tubules, or you can do just whole tissue grafting in the testis as a whole. To give you an idea, because a lot of work is done in rodent models, this is a mouse testis, and you see the rated testis, which is in between the epididymis and the testis, has been punctured with methylene blue, and you can see that you nicely see how the seminiferous tubules can be perfused. This is with a cadaver testis, so we can get some testis from the urologist in our center, and this is with Chinese ink, and you see that indeed you can fill the seminiferous tubules with Chinese ink. We did the same with suspensions of cells. It works. Grafting is even easier. You make a small incision in the tunica albuginea, so in the testis. This is a mouse testis, it's not a human testis, and you can sandwich in, if you like, small graft close than the incision and wait. Here, for example, you see a mouse testis with human tissue grafted. There is no differentiation, no meiosis possible, but that's a model showing you that, in fact, it shows you that the grafts can easily survive, can revascularize, can actually survive even in this testis. Now you can say this is all nice, this is mouse work, rat work, but the same has been done in the United States with primates, so with rhesus testis. Again, transfusion is possible, and as you can see in this slide, they used a lentiviral transvected model to make sure that you can really prove that the spermatozoa that were actually obtained in this experiment were derived from stem cells transplanted into a host. And they could also use this sperm to generate embryos, and with the genetic markers built in the model, they could really show that indeed the transplanted stem cells were able to generate not only sperm but also going through fertilization and embryonic and drive embryonic development. So here, of course, the key maybe in assisted reproduction in the human will also be that we have to generate sperm. Numbers will be low, but nowadays, even with low numbers, thanks to the intracytoplasmic sperm injection, you only need one sperm to fertilize one egg, so there is a possibility for the human too. Women, in fact, basically there is no difference between children and adult women, because both of them, they have their ovarian reserve, their oocytes are all in meiotic arrest. So typically for adult women, what we will do, or what we will try to do if we have time, is to stimulate the ovary, trying to get a lot of eggs, and then depending whether she has a partner or not, you transform the oocytes into embryos, fertilize eggs, and you can store these embryos. If there is no partner, nowadays we can store easily mature eggs. They can survive very easily. The last 5 years there has been an improvement in the cryopreservation protocol, and nowadays egg banks are available just as sperm banks. You can also take some tissue piece, so an ovarian tissue, if you like. That tissue can be cryopreserved and then can be transplanted again. So by laparoscopy, for example. You can also take small, from the small follicles in the cortical strips, so in the small tissue piece, you can also take the immature eggs, try to mature them in the lab, and then again, you're here in fact with oocyte, you can create embryos, or you can freeze the in vitro matured eggs. But the same is true for girls, in fact, because you can get tissue from by laparoscopy. You can also try to get some oocytes. Maybe we focus first on more routine strategy, which is in fact the gonadopreservation, so ovarian tissue banking. So in fact, basically by laparoscopy, you take a small biopsy, or you remove one ovary, or always one ovary, of course. Then the tissue, really the cortex where the reserve is located, is frozen. And then at a later stage, after being cured, you can in fact transplant the tissue either in the same position as it came from, or even there are other positions, like you can put it in the forearm, because the hormones, of course, they will stimulate also that location. And then basically, the tissue is put back mostly by laparoscopy. Some people do it by laparotomy. On the remaining ovary, for example, is also a possibility. There are several techniques possible. It's already been 10 years now that the first delivery was reported here in Belgium, and question mark, there is a lot of arguing around it, but nowadays we know that there is more than 40 birds reported worldwide. Of course, only the successes are reported, so we don't have real data on the success rate. Probably there are some transplants where nothing happened to. The problem is that it's a non-standardized technique. We do it in Brussels. For example, it used at Brussel, Erasmus Hospital does it, but we have different protocols, so nothing standardized. Everybody has his own cooking recipe, and we don't know which is the best one, of course. Risk, quite limited. There is always a risk for bleeding. And then the most important one is that in some of these childhood cancers, typically leukemia, there is a risk that the tissue that you're storing and eventually transplanted is contaminated with leukemic cells, and that's of course our nightmare. We also start now to preserve eggs in girls. So this is egg banking, and the eggs come from two sources. Either you go from you take eggs from the ovarian tissue that you took out. Small follicles are punctures, and then you mature in vitro the eggs up to mature eggs. Success rates about 50% maturation rate, so half of the eggs reach the stages that you can really use them later on. Or, and this is quite controversial, you apply a hormone stimulation, very short stimulation is possible, a couple of days, and then you get, again, immature eggs that you mature. It will be the same as here, but this, of course, needs a puncture, transvaginal puncture, transabdominal puncture most of the time in children. Or you really go for standard ovarian stimulation with hormones, just as an adult IVF, and you get, for example, 10, 20 eggs. Very controversial. You see, this has been done 2 years ago for the first time in the US, where a girl of 13 years old was stimulated the way an adult was stimulated. But now it's still controversial. Can you really apply these techniques to young girls too? Question mark. When you have the eggs, then in fact, nowadays there's a lot of expertise being built up because of egg banks, but egg banks in fact used to stop your own biological clock. So typically career women, 35, nowadays there is a trend, especially in the US, to bank your eggs, but in fact you could do the same, exactly the same for the cancer patients. Unfortunately, there is no reimbursement in Belgium for banking eggs, and the main reason is that the RISIF-INAMI, so the reimbursement authority, does not want to have reimbursement that also covers this type, so the social freezing. They only want to target oncological freezing, and they have problems to discriminate between the two types of groups. The truth is that in fact nowadays what we try to do is combine all the different options. Some centers they cryopreserve tissue, other centers they try to cryopreserve eggs, but the real probably key to success will be to combine everything. So for example, you could cryopreserve tissue, take out some eggs, even stimulate the ovary and then bank eggs, bank tissue, and then even do, but it's not really evidence-based, you can also give a medical treatment trying to limit the gonadotoxicity, but that's another stuff. So here you see a case, 70 years old girl, she's post-pubertal, but she's still a girl, acute leukemia, of course no partner at that age, urgent chemotherapy, so we removed part of the ovary. From that ovary still there were some puncturings or follicles, and in the end we could bank ovarian tissue and bank also 7 pure eggs. This was not wrong, you expect a little bit more, but okay, there are always variations. But this is the idea, that you combine different methods in order to offer a good prevention of fertility. What is happening today? Well, basically the start is a bit tricky, because when a new technique emerges in the animal models, 6 months later it has been done in the human too. So this is a report of 2003 about transplanting stem cells, but so far probably this is not really true. It has never been published. Another story is a story, a Belgian story, where in fact there was a first success with the transplantation of the ovary. There is a lot of discussion whether this was true or not true, but the truth is that the technique works. And that I think is very important to know, that at least our colleagues in Brussels here, they did something that really works in the end. Now in recent years, this is Nature last year, August, it has become really very, very trendy to start banking everything, and especially in the United States, there are several banks now starting to bank, for example, stem cells in boys. But the truth is that we still need a lot of new studies proving the efficiency, proving the safety of these techniques, and this is of course always finding a balance between clinical application and of course the need for more research before going to clinical applications. We are doing a lot of research, unfortunately, in the mouse. In Belgium it's not easy to get money to do the good work in rhesus monkeys, for example. But anyhow, so far for clinical application, there are many societies, for example here the British Fertility Society, that have made up guidelines. In the end, the guidelines say, yes, you're ready, you can bank stem cells in boys, you can bank eggs in girls, as long as you really tell the parents, the patients, that it's still experimental, and you cannot charge too much money for that. Patients themselves are ready, I think, at least their parents. This is, for example, a study from Amsterdam about stem cell banking in boys. And as you can see, parents consenting to take a piece of the testis is 62 to 70%. So most parents will agree that something can already be banked, although this is all quite experimental. Who should bank? That's all discussion. We in Brussel, we only go for the ones with more than 80% risk. Of course, the ones that are boys or girls with total body irradiation, bone marrow transplantation, alkylating agents, uric sarcoma with metastasis, soft tissue sarcoma with metastasis, and then of course very localized radiotherapy. Sometimes claim that you have to go for the low risks too, because you never know. But we feel on the safe side, only focusing on this group, because after all it's still experimental, and of course we sell a lot of hope with no evidence that it will truly work, although the results in animal models are very promising. Yeah, if you want to set up an oncofertility service, it's again something very multidisciplinary. You need to have gynecologists involved, but you also need the oncologist involved, pediatric oncologists, etc., etc. So to try to reach our colleagues, our patients, we tried, of course, to make use of the new multimedia possibilities, websites, for example. But what is very important is that the care path is really integrated. When the moment there is a cancer diagnosis, for example, the patient, the parents will be referred to the oncofertility team, and there, of course, a lot of people need to be consulted to see what is the best method of prevention. Is there a need for prevention? So it depends on all different parameters like cancer type. Many patients did have already some chemotherapy before, and then sometimes it's not a good idea to bank something. age, puberty status, all these things. If a boy shows up 15 years, maybe he's probably producing sperm, and it's better to try to get some sperm and to bank sperm than to bank his or his testes, of course. So there is a lot of work to be done, and basically, in fact, before you go to preservation, the midfield there is very, very active, and in order to get all things with all key players on one line, you need a very important person, and that is the SPOC. The SPOC is the single person of communication. This is the person that patients can contact, doctors, referring doctors can contact, but there's also the person that takes care of all the communication in the team, sending emails, phoning you at 11 o'clock in the evening to ask, tomorrow there will be this and that, we have to bank something, and you need really a team where there is one SPOC that is taking care of all these steps. Okay, so what you try to remember when you go home, that we have a new field in the house. We call it oncofertility. It's a new subdomain. It's very promising. A lot of techniques actually work, and nowadays also work for children. The key to success is that, of course, you don't do it as one single doctor. There is a team with several doctors involved, and the team must be available 7 days out of 7, 24 hours to 24 hours, because oncologists, if they are pediatric oncologists, they make the diagnosis and the next day they want to start their treatments, of course, and we have to be ready to step in. So that's why you really need people who want to do this and who are available all the time. For boys, we know that in fact, in animal models, spermatogonal stem cell banking and transplantation really works. So, in other words, we can try to step in. Of course, in all these models, for example, in the mouse model, you remove 3 or 4 testes to make it work. This is impossible in boy. And the key to success will be the in vitro culture. So we need to culture in vitro the stem cells in order to make it work, and that is something that's also now going on. And also with human stem cells, in vitro culture works, and seems to work always better and better. So that's good. And then, again, if you want to start or you want to refer a boy, then you have to think about who should you refer, and there is the discussion of high risk versus mediocre or medium risk. We still stick to the high risk patients only at the moment. But maybe we are. For girls, ovarian tissue banking and transplantation, it works in adults. So far, I'm not aware of any case report where it was done in a girl and then 10 years later transplant, but that will happen, I'm sure, because worldwide people are banking in girls too for cancer treatment centers. Also, in fact, we can use in vitro maturation of oocytes, which means that you can pick up immature eggs from the ovary, or give a very short slide stimulation with hormones to girls and then take out the immature eggs, mature them, and cryopreserve them. And you can also, even though it's controversial, say that you go for a full ovarian stimulation, aiming to get 10-15 eggs out, even in prepubertal girls, it works. Of course, it's quite a more difficult issue than in adult women, of course. I thank you for your attention.
Any questions? Yeah.
Reproduction.
Yes, perhaps can you tell us
something about the success rate of the different techniques at present?
Well, basically, success rate for stem cell banking in boys, even in adults, we don't know. Everybody is banking. There was one report in 2003. A Greek colleague who 6 months after the first publication in rodents was already there to say that it works in human too, but Hodgkin patients, most of them remain fertile, so very tricky. So for the stem cell banking in boys, the only evidence is the rhesus monkey models where it works. That's it. That's it. For girls, again, for girls, no evidence, although you can argue, probably that's sure, that it will work the same as in adult women. And there, every meeting there is on ovarian transplantation, there are 10, 15 births more, so that probably is working.
Okay, thank you.
Is there a risk that taking a biopsy of the testicle or of the ovary, that the procedure itself reduces the remaining fertility by inducing autoimmunity also?
Autoimmunity, not necessarily, no. But of course, if you remove one ovary, and if, for example, the gonadotoxic treatment turns out not to be that gonadotoxic, you have removed one ovary that otherwise would work. Of course, we know from adult gynecology that women with one ovary do exactly the same as with two ovaries. Whether this is true for somebody who got chemotherapy, that's something else. And that's why most of the time there's only a cortical strip removed, a biopsy part of the ovary. And the same is true for the testicular stem cell banking. But there again, if you target the high risk group, most of your colleagues will tell me that the testis on long term will be a peanut-sized testicle, it will be destroyed anyhow. So most of the time it's a hemi-orchidectomy, so half of one testis is removed. So 3/4 of the testis remains, 1/4 is removed. But yeah, but all this is discussed with the parents and with the boy or the girl.
Thank you for your talk. You mentioned the risk of contamination by eugenic cells. How do you proceed to exclude it?
Well, my research group works on the boys. So one thing that we did, especially leukemia again. So in leukemic boys, there can be an infestation of the testis. It has been proven in leukemic rats, if you transplant cryopreserve, that the other rats, the host rat gets leukemia. So there is a real concern here. So what would you do? Probably cell sorting. So we try to sort by cell sorting to remove the malignant cells from the stem cells. And our colleagues, oncologists, they were very happy with the result because the cell sorting worked at the level of 1 in 100,000 cells. To be honest, if my son would have transplantation and maybe less than 1 in 100,000 cells is still leukemic, I would not go to transplantation. So we are still working on that. The idea could be to use the specific patient-specific T-cell receptor makeup, but so far we need money to try to solve that problem. And for the girls, my colleagues work in the girls, what they do a sort of xenotransplantation. They take small part of the cortex that was banked, for example, of a girl with leukemia, and they transplant it on a skid mice. And then typically if it's infested, there will be strange tumoric growth on the mouse. If it doesn't grow, they feel at the same site. Again, you're never sure. So there is a lot of work for leukemia, I think.
Any other questions? If not, thank you very much, Dr. Tournaye. And I think there is coffee now.